Alterations in hematologic function. Anemia is defined as a reduction in the total number of erythrocytes in the circulating blood, or in the quality or quantity of hemoglobin. This condition can result from impaired red blood cell production, acute or chronic blood loss, increased destruction of red cells, or a combination of these factors. The impact of anemia varies depending on the underlying cause and the body's ability to compensate. Anemias are classified based on cell size and hemoglobin content. Size is indicated using terms like macrocytic, microcytic, or normocytic, while hemoglobin content is described as normochromic or hypochromic. These classifications help guide diagnosis and treatment by indicating the likely cause of the anemia. Two additional terms help describe abnormal red blood cells. Anisocytosis refers to variation in red cell size, and poikilocytosis refers to variation in cell shape. These irregularities can provide important diagnostic clues in evaluating the type and cause of anemia. The key physiological consequence of anemia is a reduced oxygen carrying capacity, leading to hypoxemia. Symptoms depend on the severity of anemia and how well the body compensates. Common symptoms include fatigue, weakness, shortness of breath, and pallor. These may develop gradually or appear suddenly in acute cases. Blood loss can lead to anemia either acutely or chronically. Acute post-hemorrhagic anemia is usually normocytic and normochromic and often results from trauma. Chronic blood loss may occur more subtly over time, such as from gastrointestinal bleeding, and can eventually outpace the bone marrow's ability to replace red cells, often resulting in iron deficiency anemia. Macrocytic or megaloblastic anemias are characterized by unusually large red cell precursors. These cells are abnormally large due to defective DNA synthesis, often caused by vitamin B12 or folate deficiencies. While RNA processes continue normally, the disruption in DNA replication leads to increased cell volume and hemoglobin content, but impaired division. Pernicious anemia is the most common form of macrocytic anemia and results from a deficiency in intrinsic factor, which is needed to absorb vitamin B12. This condition typically develops slowly, with early symptoms such as weakness and fatigue. When hemoglobin levels drop below 7 or 8 grams per deciliter, symptoms may include difficulty walking, numbness, weight loss, a sore tongue, and even neurological complications. Lifelong B12 supplementation is required for treatment. Folate deficiency anemia has similar manifestations to pernicious anemia, but generally lacks the neurological symptoms. Humans depend entirely on dietary folate, which is absorbed in the upper small intestine. Treatment involves oral folate supplements, usually taken daily until stores are replenished. Microcytic hypochromic anemias are characterized by abnormally small red blood cells that contain reduced amounts of hemoglobin. These anemias usually result from disorders of iron metabolism, heme synthesis, or globin production, and are most commonly associated with iron deficiency. Iron deficiency anemia is the most common nutritional disorder worldwide. Causes include inadequate dietary intake, impaired absorption, increased requirements, such as during pregnancy, and chronic blood loss, often from gastrointestinal bleeding or prolonged diarrhea. Because iron is essential for hemoglobin synthesis, its absence leads to the production of smaller red blood cells with insufficient hemoglobin. Symptoms of iron deficiency anemia typically begin when hemoglobin levels drop below 7 or 8 grams per deciliter. Early signs are nonspecific and may include fatigue, weakness, and shortness of breath. As the condition progresses, more distinct symptoms can appear: spoon-shaped nails or koilonychia, cracks at the corners of the mouth, oral ulcers, and difficulty swallowing. These features help differentiate iron deficiency anemia from other types, also called anemia of inflammation. This form of anemia occurs in individuals with chronic infections, inflammatory diseases, or malignancies. It is characterized by decreased red blood cell production and impaired iron utilization. Common underlying mechanisms include shortened red cell lifespan, suppressed erythropoietin production, an ineffective bone marrow response, and altered iron handling within macrophages. Initially, this anemia presents as normocytic and normochromic, but over time it may evolve into a microcytic, hypochromic form. Treatment is aimed at the underlying disorder. If an inflammatory or infectious cause is not identified, patients are often screened for hidden cancers or autoimmune conditions. Aplastic anemia results from the failure of bone marrow to produce adequate numbers of red blood cells, white blood cells, and platelets, a condition known as pancytopenia. This can occur due to radiation, toxins, or autoimmune destruction of stem cells. Hemolytic anemia, on the other hand, involves the premature destruction of red blood cells. This may be inherited or acquired and leads to elevated bilirubin levels, jaundice, and increased reticulocyte counts as the bone marrow tries to compensate. Polycythemia refers to the overproduction of red blood cells. There are two types, relative and absolute. Relative polycythemia is caused by dehydration, where fluid loss results in a concentration of red cells. This leads to an increase in hematocrit and hemoglobin levels, but without an actual increase in red cell mass. It's usually corrected with fluid rehydration. Absolute polycythemia is classified as either primary or secondary. Primary polycythemia, or polycythemia vera, is a rare bone marrow disorder characterized by excessive production of red blood cells without a clear stimulus. Secondary polycythemia occurs as a normal response to chronic low oxygen levels, such as in lung disease, or as a result of tumors secreting erythropoietin. Polycythemia vera is a form of blood cancer in which the bone marrow produces too many red blood cells, and often white blood cells and platelets as well. It is associated with an acquired mutation in the JAK2 gene. The disease progresses slowly and causes symptoms like increased blood volume and viscosity, leading to headaches, dizziness, and a higher risk of clotting. Management focuses on reducing red cell mass and preventing thrombotic events. Hereditary hemochromatosis is an iron overload disorder caused by an inherited mutation affecting iron metabolism. This autosomal recessive condition results in unregulated iron absorption from the intestine. Excess iron accumulates in the liver, pancreas, skin, heart, joints, and testes. Symptoms include fatigue, joint pain, abdominal discomfort, weight loss, and, in advanced cases, cirrhosis. Diagnosis is confirmed by genetic testing and elevated serum ferritin. Alterations in leukocyte function can be quantitative or qualitative. Quantitative disorders involve changes in the number of white blood cells, while qualitative disorders impair their function. These abnormalities may result from bone marrow diseases or the immune system's response to infection. In some cases, white blood cells may be present in normal numbers, but are dysfunctional, compromising immune defense. Leukocytosis refers to an elevated white blood cell count. It is a normal protective response to stressors like infection or inflammation. In contrast, leukopenia is an abnormally low white blood cell count. Unlike leukocytosis, leukopenia is never beneficial. It increases susceptibility to infections and is often seen in immunosuppressed individuals or during bone marrow failure. Granulocytosis, often referred to as neutrophilia, is an increase in the number of granulocytes, particularly neutrophils. It is the earliest sign of an acute infection or inflammation. When demand exceeds supply, immature neutrophils are released from the bone marrow, a phenomenon called a shift to the left. Once the infection resolves and the neutrophil population stabilizes, the count may shift back to the right. Neutropenia is a decrease in circulating neutrophils. It may result from severe infection, bone marrow suppression, or increased cell destruction. Severe neutropenia is called granulocytopenia, and when all granulocytes are absent, it is termed a granulocytosis. These conditions are often side effects of chemotherapy and place patients at high risk for life-threatening infections. Eosinophilia, an increase in eosinophils, is usually associated with allergic reactions and parasitic infections. Eosinopenia, a decrease in eosinophils, can occur when eosinophils migrate to inflamed tissues. Other causes of eosinopenia include Cushing's syndrome, stress, trauma, and mental distress. Basophilia, or increased basophil counts, occurs in response to inflammation and hypersensitivity. It may also be seen in myeloproliferative diseases. Basopenia, or decreased basophils, is more common and occurs in acute infections, hypothyroidism, pregnancy, and long-term steroid use. Monocytosis refers to an increase in monocytes and is often seen in the later stages of infection, particularly when neutrophil counts are low. Monocytopenia, or a decrease in monocyte count, is extremely rare and has limited clinical significance. Lymphocytosis is an increase in lymphocyte count, commonly seen in viral infections, especially Epstein-Barr virus. Lymphocytopenia is a decrease in lymphocyte numbers and is associated with immune deficiencies or destruction by drugs, viruses, or radiation exposure. Infectious mononucleosis is a benign, self-limiting viral infection of B lymphocytes. It is most often caused by Epstein-Barr virus and is transmitted through saliva, commonly referred to as the kissing disease. Other viruses, such as cytomegalovirus and HIV, can produce similar symptoms. The classic symptoms of infectious mononucleosis include fever, fatigue, sore throat, and swollen lymph nodes, particularly in the neck. Lab findings show an elevated lymphocyte count with more than 50% of white cells being lymphocytes, and at least 10% of those appearing atypical. Although the illness is usually self-limiting, the most serious potential complication is splenic rupture, which can be fatal. Diagnosis of mononucleosis can be confirmed with the monospot test, which detects heterophilic antibodies. Additional tests may confirm the presence of antibodies to Epstein-Barr virus antigens. Treatment is supportive, including rest, hydration, and pain relief, as antibiotics are not effective against this viral illness. Leukemias are malignant disorders of the bone marrow and blood. They are characterized by uncontrolled proliferation of immature white blood cells that crowd out normal blood cells. This leads to decreased red cell, white cell, and platelet production, a condition known as pancytopenia. Leukemic cells can also infiltrate other organs, contributing to widespread symptoms. Leukemias are categorized as acute or chronic. Acute leukemias involve immature blast cells and have an abrupt onset with rapid progression. Without treatment, they are typically fatal. Chronic leukemias involve more mature cells that function abnormally. These leukemias develop slowly and may go unnoticed for years until symptoms appear or blood work reveals abnormalities. Acute lymphocytic leukemia, or ALL, is most common in children and involves the overproduction of lymphoblasts. Acute myelogenous leukemia, or AML, is the most common type in adults and involves myeloblasts. Bone marrow failure results in symptoms like fatigue, fever, easy bleeding, and neurologic changes. Treatment typically involves intensive chemotherapy and, in some cases, bone marrow transplantation. Chronic myelogenous leukemia, or CML, is marked by an overproduction of mature blood cells, especially granulocytes. It is treated with chemotherapy, targeted biological agents, and sometimes stem cell transplantation. Chronic lymphocytic leukemia, or CL, is the most common adult leukemia in the Western world. It progresses slowly, often requiring no treatment at diagnosis. When symptoms such as enlarged lymph nodes or fatigue develop, therapy is tailored to patient needs. Alterations in lymphoid function include lymphadenopathy, malignant lymphomas, and plasma cell malignancies. These disorders can involve overproduction, dysfunction, or malignant transformation of lymphocytes. They may arise in lymph nodes, spleen, or bone marrow, and are frequently associated with immune system compromise. Lymphadenopathy refers to enlarged lymph nodes that become palpable or tender. Localized lymphadenopathy typically results from an infection or inflammation near the affected node. Generalized lymphadenopathy is more systemic and may occur with infections, autoimmune diseases, or malignancies. The pattern and distribution of enlarged nodes can help determine the underlying cause. Malignant lymphomas are cancers that arise from the proliferation of lymphocytes within the lymphoid system. They are the most common form of blood cancer in the United States. Lymphomas are broadly classified into two major groups: Hodgkin lymphoma and non-Hodgkin lymphoma, according to the Real classification system, which categorizes lymphoid neoplasms based on cell origin and behavior. Hodgkin lymphoma is a malignant disease that typically progresses from one group of lymph nodes to another in an orderly fashion. It is characterized by the presence of Reed-Sternberg cells, large, abnormal lymphocytes that are necessary for diagnosis. These cells originate from B lymphocytes and are typically surrounded by reactive inflammatory cells. Hodgkin lymphoma is divided into two types: classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. This slide shows a histological image of Reed-Sternberg cells, distinguished by their large, binucleated owl-eye appearance. Though essential for diagnosis, these cells are not exclusive to Hodgkin disease, so proper interpretation within the clinical context is crucial. Clinical features of Hodgkin lymphoma include painless enlargement of lymph nodes, often in the neck, along with mediastinal masses or splenomegaly. Systemic symptoms such as fever, unexplained weight loss, night sweats, and itching may also occur. With early diagnosis and treatment, typically involving chemotherapy and radiation, Hodgkin lymphoma is highly curable in most adults. This slide illustrates radiographic and pathological findings in advanced Hodgkin disease. Multimodal therapy, often combining chemotherapy, radiation, and sometimes surgery, has transformed Hodgkin lymphoma from a fatal illness into one with high survival rates, especially when caught early. Non-Hodgkin lymphomas are a diverse group of blood cancers that originate in B cells, T cells, or natural killer cells. Unlike Hodgkin lymphoma, these cancers are not limited to a predictable node-to-node spread and may involve extranodal sites. Variants include Burkitt lymphoma and lymphoblastic lymphoma, each with unique features and levels of aggressiveness. Risk factors for non-Hodgkin lymphoma include advanced age, male gender, and Caucasian ethnicity. Other contributing factors include immune suppression, autoimmune disease, certain infections like Epstein-Barr virus or HIV, exposure to carcinogens, and history of organ transplantation. These risk factors may alter immune surveillance or introduce oncogenic triggers. These lymphomas are driven by genetic abnormalities such as chromosomal translocations that activate oncogenes or inactivate tumor suppressor genes. Clinically, they often present as painless, generalized lymphadenopathy. Treatment strategies depend on the specific subtype, disease stage, and patient health, and may include chemotherapy, immunotherapy, and stem cell transplantation. Burkitt lymphoma is a highly aggressive B-cell non-Hodgkin lymphoma, most common in children. It often manifests as a tumor in the jaw or facial bones. There are three main forms: endemic, which is linked to Epstein-Barr virus; sporadic, and immunodeficiency associated, often seen in AIDS patients. Prompt diagnosis and intensive combination chemotherapy are critical for survival. This image highlights the rapid and destructive nature of Burkitt lymphoma in pediatric patients. Despite its aggressive growth, Burkitt lymphoma is one of the most curable childhood cancers when treated with prompt, aggressive chemotherapy regimens. Lymphoblastic lymphoma is a rare, aggressive form of T-cell lymphoma seen mainly in children. It originates in the thymus and presents with painless lymph node enlargement or a mediastinal mass. Because the malignant cells are immature T cells, the condition closely resembles acute lymphoblastic leukemia. Treatment involves intensive combination chemotherapy protocols. Multiple myeloma is a cancer of plasma cells that accumulate in the bone marrow, forming tumors and disrupting normal blood cell production. It leads to the formation of lytic bone lesions, hypercalcemia, kidney failure, anemia, and recurrent infections. Patients often have a history of monoclonal gammopathy of undetermined significance. Treatment options vary and may include chemotherapy, stem cell transplantation, and immunomodulatory agents. The spleen can become enlarged, a condition known as splenomegaly. This may be due to congestion, infiltration, or overactivity. Congestive splenomegaly is typically caused by liver disease or heart failure. Infiltrative splenomegaly occurs when cells, such as cancer cells or macrophages, accumulate in the spleen. Hypersplenism refers to excessive spleen activity, which leads to anemia and low counts of other blood cells. When necessary, splenectomy is the treatment of choice. Platelet disorders are categorized by quantity. Thrombocytopenia is defined as a platelet count less than 150,000 per microliter, and it increases the risk of bleeding. Thrombocythemia, on the other hand, refers to an elevated platelet count above 400,000, and it increases the risk of clotting. Both conditions may be primary or secondary and are associated with various underlying diseases. Thrombocytopenia becomes clinically significant when platelet counts fall below 100,000 per microliter. Spontaneous bleeding may occur below 15,000, and severe, potentially life-threatening hemorrhage is possible when counts are under 10,000. It's important to rule out pseudothrombocytopenia, a lab artifact that falsely suggests low platelet counts. Thrombocytopenia can result from decreased production of platelets, as seen in viral infections, chemotherapy, radiation, or bone marrow failure. It can also be due to increased consumption, as occurs in heparin-induced thrombocytopenia, immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, or disseminated intravascular coagulation. Heparin-induced thrombocytopenia, or HIT, is an immune-mediated reaction in which IgG antibodies target the heparin platelet factor IV complex. This leads to platelet activation and thrombosis, despite a low platelet count. The condition is treated by discontinuing heparin immediately. Immune thrombocytopenic purpura, or ITP, is caused by autoantibodies that attack platelet glycoproteins. In the chronic form, antibody-coated platelets are destroyed in the spleen. The acute form, often seen in children after viral infection, typically resolves spontaneously. Symptoms range from petechia and purpura to life-threatening hemorrhage. Thrombotic thrombocytopenic purpura, or TTP, is a rare condition where platelets form small clots, or microthrombi, in the vasculature. These clots block blood flow and lead to organ damage. TTP can be familial or acquired and may present with fever, neurologic symptoms, and hemolytic anemia. Immediate treatment is critical. Thrombocythemia is defined as a platelet count above 400,000 per microliter, with symptoms typically emerging when counts exceed 1 million. It can be primary, caused by bone marrow disorders, or secondary, triggered by inflammation or following splenectomy, where platelets are no longer sequestered by the spleen. Essential or primary. Thrombocythemia is a myeloproliferative disorder caused by a defect in megakaryocyte progenitor cells. These cells produce platelets excessively, increasing the risk of clotting or bleeding. Treatment aims to reduce platelet counts and prevent complications such as stroke or thrombosis. Qualitative platelet disorders occur when platelet numbers are normal, but their function is impaired. These disorders can be inherited or acquired and often present with prolonged bleeding time. Symptoms include petechia, purpura, mucosal bleeding, and bruising. Causes include medications like aspirin, kidney failure, and liver disease. Coagulation disorders are due to abnormalities in clotting factor production or regulation. They include impaired hemostasis, thromboembolic disorders, and hypercoagulability. Impaired hemostasis can be caused by vitamin K deficiency or liver disease, as both are essential for producing clotting factors. Coagulation disorders are due to abnormalities in clotting factor production or regulation. They include impaired hemostasis, thromboembolic disorders, and hypercoagulability. Impaired hemostasis can be caused by vitamin K deficiency or liver disease, as both are essential for producing clotting factors. Disseminated intravascular coagulation is a life-threatening condition characterized by systemic clotting and bleeding. Fibrin clots form in small vessels, reducing blood flow to organs and triggering multiple organ failure. Simultaneously, clotting factors and platelets are consumed, increasing the risk of uncontrolled bleeding. The most common cause of DIC is sepsis. Signs of DIC include bleeding from 4 sites, purpura, petechia, and hematomas. Severe cases may present with cyanosis of fingers and toes. Treatment involves addressing the underlying cause, providing supportive care, and sometimes administering clotting factors or anticoagulants cautiously. A thrombus is a clot attached to a vessel wall, while an embolus is a clot that circulates through the bloodstream. The 3 factors that contribute to thrombosis, known as Virchow's triad, include vessel injury, abnormal blood flow, and a hypercoagulable state. These clots may lead to heart attacks, strokes, or pulmonary embolism. These are inherited conditions that increase the risk of clot formation. They include mutations in platelet receptors, coagulation proteins, or fibrinolytic pathways. Most are inherited in an autosomal dominant pattern. Testing for thrombophilias may be considered in patients with early or unexplained clotting disorders. Acquired conditions like protein C or S deficiency, antithrombin 3 deficiency, or antiphospholipid syndrome can also lead to abnormal clotting. Antiphospholipid syndrome is an autoimmune disorder in which antibodies target phospholipid binding proteins, increasing the risk of thrombosis, miscarriage, and stroke